We thought over these set of short talks today that we would bring the last decade of us working together on sort of where have our successes happened and what are some of the challenges that we need to proceed. And I have been charged with the task of looking at antiretroviral therapy. Maybe. So I think everyone in this audience is well aware of the fact that with the widespread use of antiretroviral therapy, that both the incidence and prevalence of HIV are decreasing worldwide. This is data, again, looking over the last decade from the UNAIDS report. The blue line represents all adults, the green line women, the red line men. And so all of the curves are paralleling each other. But again, I want to bring to your attention, and I think no one in this audience needs to know, that the number of women living with HIV, both in terms of prevalent cases as well as new cases, has for the last decade been higher than that of men. And if we look at the global epidemic, this is again WHO data from 2018, there are now 37.9 million people living worldwide with HIV, the vast majority of them adults. But so far, they have not been able to figure out what proportion is women, but I think we can anticipate that, again, there are slightly more women than men, so probably of the order of 1.7 million women living with HIV globally. And some work from many of our colleagues, and this has come from Bog Hogg and people at the NA Accord, looking at the impact that antiretroviral therapy has had on life expectancy, taking as the index case a 20-year-old male living with HIV in a high-income country. And this has demonstrated that with the advent of antiretroviral therapy, that we've been able to increase that life expectancy from approximately 20 at the early part of the epidemic to now much over 60 years of age. And people and women living with HIV are now entering into the geriatric years of their life. But fortunately, this change has also been described in the developing as well as in the developed world. And this is some data from a number of sites in Africa, again showing that in the era of access to antiretroviral therapy, that again we are seeing the improvement in life expectancy in persons living with HIV in resource-limited settings as well. And that really comes down to the use of ART therapy. And when we started this conference, ART for women was largely restricted to giving women ART for the prevention of maternal child transmission. And fortunately, over time, we've come to the circumstance where we now give women HIV therapy for their own health as well. Again, this is data coming from the WHO looking at the distribution of ART by gender. And now women are starting to win, right? So not only are we getting antiretroviral therapy to prevent maternal child transmission, but for our own health. And because women often are more likely to come into contact with the healthcare system, overall throughout the world, women are more likely to access HIV therapy now than men. But which one should we use? And this is a slide that I used at this conference 10 years ago, and it hasn't changed. Most of the pivotal trials of antiretroviral therapy are in men. Typically, the proportion of women is less than 20. This group has pushed, and now every trial, every pharmaceutical study, every journal that reports on antiretroviral therapy does do the sub-analysis by gender, but even then, it's underpowered to show any differences. I think most of us will agree when we look at the studies over the years that there really isn't much difference in terms of overall efficacy, but clearly there have been differences in toxicity. And when we look at all of the guidelines, the only place they talk about gender is that little asterisk, what to do if women are thinking about getting pregnant. Are we doing any better? Nah. So here are the most recent pivotal trials of antiretroviral drugs that many of us are participating in our clinics. What is the percentage of women? 10 to 25%. So many of us said, well, those are naive trials. It's often hard to get women into naive trials because they need to build that trust with the clinic and feel good about it. So what about the switch studies? Nah, not doing any better there. So these are all of the trials recently in which people who are suppressed on antiretroviral drugs are changed to another agent. And again, the proportion of women remains poor. So what are the barriers? Well, the clinics say, well, the proportion of women in our clinic, in our site is small, and the proportion of women we get into the trials is really relative to that which we see in our clinic, fair enough. We still have these lines within these protocols that women need not only one, but multiple methods for contraception, and often they're not covered by the trial. Many of the trials now want patients to sign on for 3 years, 4 years, 5 years, and many women are uncertain of their pregnancy intentions over that period of time. And they often have lots of other demands, their children, their partners, their parents, and often when you look at the large trials, the reasons that women leave the trial are for these other reasons rather than for virologic failure or toxicity. The other thing is women do not have that natural support group to encourage each other to go into clinical trials, and many women living with HIV don't know someone else with the disease to tell them. And so trust is really underlying their involvement in trials. So what do we do? And we've certainly been having a lot of conversations at this meeting and with our pharmaceutical partners. How do we help? So let's choose centers and investigators with large female clinic populations. And I think that's a strength of this group over the years, is that we've been starting to encourage and put each other forward to be the people that run these trials in our centers. I think we've been seeing that trials more often now are moving to places like South Africa, Russia, South America, where there are more women that can participate in studies. We obviously drive that compensation for transportation and childcare. And a lot of the studies in Africa are now having a lot of success in getting women in by linking participation in the trial to their ongoing health care. And that's often a very important factor to get women to participate. Our pharma companies are now all coming up with quotas. We need to get 30% women in this trial. That's fantastic, but stick to it. And that's been one of the problems, is they make the quotas and then they change the rules. The other advance that we've made, and I think this group has been instrumental in pushing it, is that we now have some women-specific trials. And the two of note was the WAVE study, which was the initial study of elvitegravir in women, and our own Kate Squires was the leader on that one, and Sally Hodder. The other one was a dolutegravir area study in women. And the advantage of these two studies is they show different antiretroviral regimens in women, so that we don't want to pick what regimen is better for a woman than a man, but within a woman, what's the best regimen to minimize her toxicity. So great studies, well-powered studies, beautiful studies. What was the problem? They were the poster in the corner at CROI. Stuck. Can we advance the slide back there? I am stuck. Pardon me? No, back. Yeah, but back. One more. One more. One more. Okay, so these women-specific trials, so why are they important? As I alluded to before, most of the trials do show that virologic efficacy is similar, but over the years, we've come to learn that there may be differences in toxicity. So in the early days, we saw more rash and hepatitis with nevirapine. We saw more lactic acidosis with D4T and DDI. The patterns of lipodystrophy were different. There were different rates of diarrhea, nausea with the protease inhibitors. And the other thing is women often have different thresholds for tolerating adverse events than men, and so may be more or less likely to leave a trial because of a specific adverse event. What sample size do you need to show a change in adverse event? So if there's an adverse event that's at 3 times frequency, you need 200 exposures to show that that problem is twice as common in women than in men. And if it's something that happens at only 0.3% frequency, you need 2,000 exposures. Think about how many clinical trials have that number of women in them. Not very many. And so I think all of us recently have reflected upon the ADVANCE study, which was a study of antiretroviral naive patients in South Africa, again showing no difference between men and women in terms of virologic efficacy, but clearly showing an impact of these therapies on weight gain in women, with the women receiving tenofovir, alafenamide, and dolutegravir gaining 16% of their body weight over 96 weeks. If we did not have a significant proportion of women in this trial, this factor would never be observed, and clearly this is an important factor that needs to be studied and needs to be understood as we manage women in our clinics. What about older women? Okay, the perimenopausal is a time when there's increased comorbidity with the loss of estrogen protection. It may happen earlier in HIV, and we really know nothing about the fact as to whether or not we need to change antiretroviral drugs or their doses with age, with menopause, or declining renal function. And we have very little studies looking at the interaction between antiretroviral drugs and hormonal replacement therapy. And our women are aging with HIV, and this information is going to be necessary. So what are the successes? We have shown that effective antiretroviral therapy has prolonged the life of women living with HIV. Women increasingly have access to these therapies. These therapies work as well in women as in men. We now have women-only antiretroviral naive studies which help us choose better tolerable regimens for our women. There's a move to start to let more women get into trials, and if they do get pregnant in the trial, to be able to continue in that trial so that we'll learn some more information. And I think companies are starting to come up to the plate to recognize that if they are making some rules about how many women are going to be in the study, to stick to those strategies. Where are the gaps? We're not there, okay? We still need to get more women into these trials. And we stand here 10 years after we started this conference, and I could not tell you what the optimal antiretroviral therapy for a woman is today. And as our newer delivery systems that we're going to hear about over the course of these conferences continue to evolve, we need to push implementation science projects to ensure we find out which of these regimens work best for women. I thank you.